So if we know that this is a blood vessel right here, and there it has fluid, obviously we have fluid running through our blood vessels, this is also included in the extracellular space as well. So that's where you get intravascular. So intravascular, really what we're talking about is plasma, right? So blood is made up of different components. It's made up of plasma, RBCs, which carry oxygen, WBCs, which help with infection, platelets that help with clotting. And we know that blood just helps with the heart and the circulation, right? So any type of extracellular fluid is just talking about fluid outside of cells. So that includes plasma, that includes intravascular space, which just means in the actual vessel, that includes interstitial fluid, which is between the cells and the tissues. And then the last one you have is transcellular, but we don't really talk about this. It's basically just like CSF, pleural fluid, so in the lungs, synovial fluid, so in the joints. So if we were to get like a tissue slide, like under a microscope, and we're going to see this exact thing within like, let's say like a joint, but we also would see like synovial fluid depending on what location we would be in. So to kind of explain this information for lymph, what we're talking about is the intravascular space, which has plasma, which also has blood as well. We know that that's going through your veins, your arteries. Basically, it comes out, so that plasma, that intravascular fluid comes out of your vessel, and it does that through capillary permeability. And we'll talk about that as we go further, so it might be a little bit confusing. But basically, lymphatic fluid is the interstitial fluid that once came from the plasma intravascular space, if that makes sense. So then once it's out there, basically it's saying that this interstitial fluid, then once it goes to the vessels, is called lymph. So I feel like it helps just to go through that because we're going to talk about third spacing. And if you don't know the differences between each, then it kind of gets confusing. So again, just to kind of summarize everything, because it might be confusing, extracellular fluid, any fluid outside the cell. So if that's intravascular, interstitial, transcellular. Intracellular is only talking about inside the cells. So interstitial is in between that tissue and those cells. But also when we're talking about extracellular fluid, we're also talking about intravascular, which includes plasma, white blood cells, blood, basically that whole entire things going through your vessels as well. So I hope that helps. And I think it'll make more sense when we talk about third spacing in a second. Okay, so now we're going to go to lymph nodes. So again, we kind of talked about it already. So they're placed around the body that house macrophages, lymphocytes that actively filter invaders from the circulating lymphatic fluid. And so the fluid enters those vessels to the lymph ducts, and then they enter the general circulation after. So they help basically filter and clean that bloodstream. So then when we're talking about the thymus, I think we remember the A&P model where it's larger in the child than it is in the adult, and you can't even see it. They produce thymosin. So this is a hormone that activates T cell production. And if you were to just remember that, it's the T for T. In terms of the bone marrow, this is within the cavities of the bone, right? So we know that. And so we know that this is where T cells and B cells form. The only thing is that B cells stay to mature in the bone marrow, whereas the T cells migrate to mature in the thymus. And so I would just remember like T for thymus, right? And then B for bone marrow. So they both start there and are created there, but then they both differentiate once they're becoming mature. Okay, and then once they're matured in the thymus, we can see those differentiated T cells. So we see like the suppressors, the helpers, the cytotoxin, which we'll talk about in a second as well. So for the spleen, she won't ask you these questions again, but I think it does help just to know. She might ask about like the bone marrow, that type of information, but even with the lymphatic fluid, she won't ask you about that. I just wanted to teach you guys because I know that that stuff can get confusing. For the spleen, it's also part of the lymphatic system. It serves as a blood filter. It has compartments that contain red and white splenic pulp. The red pulp helps filter old damaged RBCs, and that makes sense because it's red pulp and stores the blood. And then the white pulp houses lymphocytes and macrophages like a lymph node. So again, that makes sense because I think about it like white pulp, white blood cells. It's again kind of a redundant organ. Like some people are able to go without it, they get it removed, it's not going to kill them. But if you already are immunocompromised and you get it removed, then that obviously won't help the situation out. And so for tonsils, adenoids, and Peyer's patches, these are just any type of closed mucosal surfaces of the body that help protect against invaders, right? So you can see the adenoids here, the tonsils, and then we have the Peyer's patches located within the mucosa of the small intestine. So again, tonsils protect against inhaled pathogens for the throat. Adenoids protect against inhaled pathogens for the nasopharyngeal region, and then the Peyer's patches, they help protect against pathogens in the intestinal tract, right? So you don't need to know that, but just helpful to know. And so we'll go back to this section because if some of you guys are still confused, I'll kind of explain it in a second once we get to sepsis. So in terms of leukocytes, so white blood cells, right? So we're talking about in the clinic setting. I know they make you guys like differentiate between the different types. In a theory setting, I don't think she asked us any questions regarding like neutrophils or about this, but I could be wrong. It could always change. I don't know what question she's going to decide to do. So basically, leukocytes are formed in the bone marrow and they mature in the bone marrow in the thymus, right? Remember, T cells for the thymus and then B cells for the bone marrow. They protect the bone against infection. And then there's 5 different types, which include the phils and the lymphocytes, so which are T cells and B cells. So I think when we differentiate between like granulocytes and agranulocytes, I would just know granulocytes have a granule in the cytoplasm. They release histamines and other substances, but they do this by increasing capillary permeability through vasodilation effects and inflammation. So you don't really need to know that, and we'll talk about that in a second about what it means in terms of vasodilation, histamine, inflammation, and the infection response that usually the body gives. But I would just know that granulocytes, we're talking about the phils in that situation. So neutrophils, basophils, eosinophils, and then when we're talking about agranulocytes, we're talking about just the other ones, right? So the phils and then the other ones. So neutrophils, this is for early, and this can just help you in a clinic setting, I think. This is for early inflammation. Basically, if you see them be high in a clinic setting, basically you know that it's probably a newer infection as well, as these are the first leukocyte that goes to the infection site. So it's early inflammation that destroy bacteria. Basophils are responsible for releasing heparin, which we know is an anticoagulant, and histamine, which again helps with that inflammatory response. So both of them help with the inflammatory response, and that's what basophils are important for. And then additionally, it helps with allergic responses as well, so that we can vasodilate those vessels in an allergic reaction because we want more blood flow to that site. And so basically, when cells are injured, or you have a, let's say you're having an allergic reaction, your cells are going to release histamine, which allows those vessels to dilate, so they're becoming more permeable. And then basically, they just help to modulate the release of histamine and cytokines. And we'll talk about what that is as well. But basically, just remember inflammatory response, allergic response. Eosinophils, they destroy allergens. So if you're having an allergic reaction, and they combat parasite infections. The way I just remember this one, if you remember like the immunoglobulins, like IgA, IgE also is talking about parasites. She won't ask you this, but again, I think it's just helpful to know. And then with agranulocytes, they don't have granules, right? And then we're just including the other ones other than the phils. So monocytes and then lymphocytes. So monocytes, basically, they just present invaders to T cells for destruction, and then in the tissues, they develop to macrophages. And so I would just say it's important to know like the why behind this. So yeah, monocytes just turn into macrophages once they're in the tissues. And that's important because we remember that macrophages eat microbes and parasites, right? So I think that's just something we should know, just because we talk about sepsis and the inflammatory response, we still are talking about macrophages, and we will talk about like heparin and histamine and that inflammatory response there. So for the lymphocytes, they're just active in both B cells and T cells, and they defend against microorganisms, right? So again, don't feel like you have to know that, it just helps. For other cells, cytokines are small proteins that help to regulate the immune system and the response. They have signaling effects that enable them to signal cells. So essentially, they just act as a messenger of the cells. So basically, they're just communicating with one another, saying, hey, this is an invader. We need to signal. We need to basically send those T cells, those B cells to go help and attack that. So interleukins are a type of cytokine, so they go under that help with that communication. And then there's another thing, you don't have to know this, tumor necrosis factor alpha is made by those macrophages, but they also help with the inflammation response and the immune response overall. So cytokines just act as messengers. So just remember that, they just act as messengers. And then with the complement system, which we will talk about, so it's just important that you do understand this. With the complement system, basically what it is, it's a cascade of proteins that provide defense against pathogens. So they complement the immune system, and basically they allow those macrophages to go to those pathogens and destroy them and eat them. And then it's also able to activate every component of the inflammatory response, which includes heparin and which includes platelets, which we'll talk about in a second. But complement system, cascade of proteins, they have a macrophages and inflammatory response. That's what I would remember for that. And we'll talk about that in a second. So if things are seeming confusing, I think it'll tie together once we talk about sepsis. So with the immune responses, this just means like immunity refers to the body's ability to resist infection and disease. So how your body's going to react once it sees that it's sick, once it detects a disease, a type of infection, invaders, pathogens, things like that. So with innate immunity, so I would just think about this. She will ask a question about this, I think, because she always does. She'll talk about like, and we'll get to acquired, but she definitely will probably test over this. If not, it might be on a quiz. Just because I remember getting confused for a second because it can get confusing because there's a bunch of them. So with innate immunity, this is non-specific. So this is without memory and is more immediate, essentially natural immunity. So the way that I think about innate, the definition of innate is literally existing in, belonging to, or determined by factors present in or at birth. So it's literally something that you are almost born with. So when we talk about innate immunity, we're talking about two different responses that go under it. So we're talking about innate immune response, which is the first line, and we're talking about inflammatory response, which is the second line. So these are basically ways that your body is reacting in case we have an invader or a pathogen coming in. So with innate immune response, that's that first line, we're just talking about barriers. So things that we already have set, like you don't have to do anything. There isn't anything that your body has to do. It's just things that we already have mechanically, things that we already have physically, things we already have chemically, right? So with physical barriers, we're talking about the skin, we're talking about mucous membranes, we're talking about cilia, right? So anything like that, they're all barriers. So if I were to have like a pathogen, it can't just come through my skin, right? You have that barrier. Mucous membranes, we're talking about like the Peyer's patches, the adenoids, the tonsils, those are all physical barriers that help stop those pathogens from coming into my mouth, coming into my nose, and coming in, if they do come in, coming through my intestine, right? So just actual physical characteristics and barriers. So biochemical is acid in the stomach, the saliva, and mucus. So kind of all of those liquids and those fluids that help stop that, right? And break down those things. So we know that saliva, mucus can help break it down. Acid also helps break those things down as well. So biochemical, and I think it makes sense because chemical kind of ties to acid, kind of ties to fluid. So I would just think about it like that. And then with mechanical, these are actual actions that you're doing. That's how I would think about it. Like it's an actual, like it's a mechanical action that you're doing. So coughing, sneezing, vomiting. So again, with the first line, these are things that you're just naturally, like you don't have to do anything, you just have them, right? With the inflammatory response, this is the body's second response if those barriers were not working. So let's say if somebody doesn't have, or if they have a burn, right? We know that the one of their first line barriers that are gone is the physical barrier, right? Because their skin's not able to keep all of these pathogens out. So the body's response would be to have inflammation, because if you're inflamed, that prevents all of those pathogens from coming in. So basically how it works is when those first lines are breached, right? So any of those physical, biochemical, or mechanical barriers, usually this results in tissue damage or a break in the skin, right? Like a burn. Inflammation prevents and limits the infection and further damage in the area. And we're talking about the complement system, right? So the cascade of proteins that help bring macrophages to eat that. And additionally, they also help with that inflammatory response. So the initiation of inflammation response includes vasodilation and permeability of capillaries due to histamine being released. So there is a difference between vasodilation and capillary permeability. So when I was talking about the fluids, the reason why I was bringing that up is because when we talk about third spacing, we talk about the permeability and vasodilation of an infection, it kind of helps to know the difference between those fluids. So to kind of go down here to explain that. Okay, so the difference between, let me just say this. So you have the intravascular fluid, right? We know that's a part of the extracellular fluid, because it's anything other than the cell, any fluid outside of the cell. When you're taking a blood pressure, I think this is just helpful to know, because I forgot to say this earlier. When you're taking a blood pressure, you're not taking a blood pressure like over the interstitial fluid, anything like that. You're taking a blood pressure over the actual intravascular space, right? The blood vessels, how are they looking like? So when we're talking about like vasodilation and things like that, we're talking about we're having more blood flow. So the vessels, if they're constricting, they're smaller, but if they're bigger, then you're having vasodilation and more blood flow. So let me be more specific in terms of what an infection looks like. I just wanted to put that out there for that information, but in terms of what an infection looks like, So you have vasodilation. So the reason why your arteries and veins are trying to become bigger is because in that intravascular space, you had, so in between the vessels, you have your blood, which is made up of your plasma, your red blood cells, which carry oxygen, your white blood cells, your platelets, anything like that. So you have all of that running through your vessels. If we are constricted, how are all of those white blood cells going to travel to that site, right? So our body naturally, if the draw really weird, but our body will naturally vasodilate so that our vessels can become widened. And once they're widened, all of those RBCs, all of those white blood cells, everything like that are able to go more through. So the bigger that they are, that's why we're vasodilating, because we want all of those white blood cells and that blood flow to go in, right? So we know that intravascular space has that plasma, has that blood, has those red blood cells, white blood cells in between those vessels. And when they're coming out, they're just wanting to vasodilate those so that we have more blood flow. So more white blood cells, more red blood cells are able to go through. So the one thing with the difference with vasodilation and then capillary permeability is when we're talking about permeability, we're talking about, so if this is the capillaries and we're talking about like veins and arteries and everything, let's see if I can draw this. Capillary permeability means if we're going through the vessel, right? So we're going through those capillaries, we're going through the walls of that. So all of these walls right here, we're going through. Because technically your body can vasodilate, but why does that even matter if you're not able to have any permeability? If any of those white blood cells, red blood cells are able to go through those capillaries, through those veins, but you don't have capillary permeability, there's no point of having that tissue site or having that infection site be protected or saved or whatever, because there's no permeability. You have to have permeability as well so that all of those white blood cells can go through the wall of those vessels and go into the interstitial space. So I don't know if that makes sense, but basically from this paragraph, so while vasodilation brings more blood, right, because it's bigger, and basically it's transporting all of those immune components, it's the increased capillary permeability that also helps to enable these components to leave that blood vessel and do their work to the site of the injury. So basically, without capillary permeability, those components would just technically stay in the vessels themselves, and we want them to be together, right? So we want vasodilation and we want capillary permeability, because when we go back to the beginning again, you have those vessels that have all of those components in there that are a part of that extracellular space. But if, let's say I had a tissue site right over here, I'll do it in a different color, because if I had a tissue injury right over here, and here are my red blood cells, my white blood cells to help fight against infection and everything. But if I don't have any capillary permeability through my capillaries, through my veins, through my arteries, none of that will be able to travel into that interstitial space and then go to that tissue site. So you have to have both. So I hope that kind of makes sense and breaks it down. You have to have both of them just because they're different things. And I think it helps knowing the difference between those, because with one, you make sense because you want to bring all that stuff, but capillary permeability just means that we're having those things, those components leave the bloodstream and move into that interstitial space so that they can go to the tissue site. Because your injury might not just be at a vessel, it can be through an actual injury, through an actual tissue site. So if I were to get like a cut on my arm, you know, it's not touching my artery, it's not touching my veins, it's having to, I know that my veins in my arm are going to be, and my arteries, my capillaries are going to get all of those components. And then with increased capillary permeability, they're able to leave my vessels and go into the interstitial space. So that's why with third spacing and in an infection, you end up having that injury in that site. It's inflamed, it's warm, things like that. And that makes sense because of the vasodilation effects. But when we're talking about permeability and that fluid shifting, all of that fluid that was in the intravascular space, so all of your blood, your plasma, your red blood cells, your white blood cells, anything like that, that's all now moving into your interstitial space. So that's why you end up seeing that edema. So I hope that makes sense. So basically that fluid can accumulate, and that's why with sepsis we end up getting basically edematous. So I hope that kind of explains stuff, and I'll explain that once we get to sepsis as well. But basically, initiation of inflammation response includes vasodilation. and permeability of capillaries due to the histamine being released. Again, histamine helps work with the inflammatory response. So vasodilation increases the blood flow. So we talked about this, which moves leukocytes to the tissue so that invaders are destroyed. So the bigger the vessel are, the more white blood cells can go to that site. And so as a result, the signs and symptoms you see, and it makes more sense because if I were to be vasodilating, all of my, I never just think about it like all of your red blood cells, white blood cells, your blood is all going to that specific region. It's going to be red. And then eventually you're going to see edema because of all of the fluid that's coming there. And then the permeability allows that fluid in the intravascular space. So your blood, red blood cells, white blood cells to go to that interstitial fluid, right? And then now you have that edema right there. And that helps prevent anybody from coming in as well. So that's why you'll see those signs and symptoms. You'll have pain just because you're swollen there. You'll have redness and heat because of that increased blood flow. And then because of that inflammation, then you'll have those signs of having a fever, having chills, having discomfort, and having elevated WBCs. So that kind of is explained through this picture here. So if you see it, so you have the inflammatory response, there's vasodilation, and there's increased capillary permeability, but they both have to go together in there. So it can't just be one. So it can't just be one or the other. It has to be both of them because they both help. They increase the blood flow to that site so that all of those WBCs can go there. And then the permeability is what allows those WBCs that are in the vessel to be able to go now into that other space, the interstitial fluid, to now travel to the tissue site. So I hope that makes sense. But yeah, and then you see that there with these signs and with these symptoms as well. Okay, so with innate immunity, just remember first line, anything you're naturally born with. Second line, we're just talking about inflammatory response, right? Okay, so now with acquired adaptive immunity, these are specific. So it's a little bit confusing because under this one, you have naturally acquired, you have actively acquired, and then you have two other categories, and that's passive and active. Yeah, passive and active. Okay, I just want to make sure I'm saying that right. So it's specific. So it's something that you acquire. It's not something that you are born with naturally. You get it. And I wouldn't say it's something that you're born with naturally because there's an example on here when we're talking about the newborn one. It gets a little bit confusing because it's like, well, technically you are born with it, but I would just think about acquired as you are acquiring it through your environment, if that makes sense. So you're technically just acquiring it through your environment. So this consists of cell-mediated, so T cells, and neural-mediated response, so B cells, so T cells and B cells. And basically this again has to deal with the natural exposure to these things that we're going to talk about. So with naturally acquired and actively acquired, you're going to have two different types that go into this. So it's going to be the two different types are active and passive. So when we're talking about active, we're talking about T cells are produced after exposure to an antigen, right? So I would just think like A, active, you're getting an antigen. So A for A, right? And then an example of like natural or artificial, I would kind of think about it as okay, so if I'm getting an infection, that is more of a natural thing in my life that I'm going to get. Like, regardless, we are all going to acquire and naturally receive an infection one time in our lives. And what's good about that, it does suck to be sick, but the good thing about that is that you have those antibodies that form after you get an infection. So if you were to get sick again, your immune response would be better off to fight off that infection, and it might not cure your infection. It's not saying that you're never going to get this infection again. It's just it's helping your immune response to have a better response to it next time. And additionally, so you're not feeling as sick, you might be able to handle it better, things like that. Okay, so I would just think about like an infection is more of a natural part. For the vaccination, it's artificial. So I would just kind of think about like that, like an artificial vaccine, like we're specifically making and pulling something like in a syringe and we're giving it to somebody. So it's more artificial, but this is still exposing somebody to an antigen, right? Because we know that vaccines are, they have antigens in them. They help your body to be able to produce those antibodies once they're injected in you. So again, they help prevent against these, let me mute somebody. And they help protect against any type of infection disease that you might be able to come across, right? So they just expose you to an antigen. So active for antigen, infection more natural, the vaccinations more artificial. And then with passive, you have formed antibodies or T cells, which are transferred to one person from another. So this is what makes sense. So I would just think like passive is literally you passing something. So somebody or one person, one animal, whatever it is passing one thing to another. So passive meaning we're passing something, we're passing some type of antigen antibody. So an example she gives you is a newborn acquiring immunity from mom through the placenta. And I remember her asking a question about this because it does get confusing. So this is a natural and a passive thing. So just think about it as a newborn acquires immunity through the placenta because it's passed. That is something that they have to pass through. So it's a natural part, but it's also passive. So it gets a little bit confusing because you have those like different categories, but I would just think passive for pass, and then it's more natural, right? Like a newborn with a mom. So it's more natural in that way. And then same thing with, so the next part is immune serum, like snake venom or anti-serum. So this, I would just think about it like it's artificial, right? It's not like a person, we're talking about an animal, right? So snake venom, if you end up getting it, it's an artificial type of exposure that you're getting. But again, it still is an animal passing you something. So I would just think about it like that. So I believe like the question, I believe I have it on the practice questions, is like what type of immunity is a newborn who's acquiring immunity from the mom through her placenta. And the answer would be, I remember she asked it because it was confusing a little bit. I think she said it is passive immunity. That was like the answer, I'm pretty sure. But I would just pay attention to what she's asking for, because she'll say like innate immunity, and then she'll probably put like artificial, and then she'll put like active. So it's all different like categories, and there is a question on there, so you guys can look at it, but just make sure you're paying attention to what it is. And if you have to draw it out like on a piece of paper really quickly, I definitely would do that. I would just kind of follow, and this is what I did. I followed it through here. So you have that innate immunity, so that first line, which we're talking about the barriers, second line talking about inflammatory response, and the acquired, we're talking about the third line of defense. So what's natural, and then what's artificially acquired, and then going into the active passive differentiations between each, right? So you're getting past something that's going to be passive, and then things that are naturally you're going to receive throughout life is how it's determined here. And then things that you artificially get, it's not something that we're going to have naturally. It's not something that you are you should be receiving in terms of like with the immune serum and everything, but they're made to help prevent. So I would just say they're artificially given. So I don't know if that kind of helps out, but I definitely would try to draw it out if you're getting confused. But I do remember she does ask a question about some type of immunity on here. So to go through cell-mediated responses, any moral-mediated responses, so we're talking about B cells and T cells. She really won't go into this a lot, but again, I think it's helpful for you to know how this works. We're talking about T cells. She can ask a question about it, so I would just kind of pay attention to that for sure. So I think we remember the acronym like be humorous. So I think just that's what I would think. So be humorous. So just B cells, humoral mediated immunity. So basically, we know that B cells are formed and mature in the bone marrow. When a B cell encounters an antigen, they match its receptor and it gets activated. So they're also differentiated into different types. So we have plasma cells and memory cells. So plasma cells are basically antibody factories. They help produce those antibodies, which antibodies help mark those pathogens for destruction. So if they're able to come in your body, those antibodies label them and basically tell them, hey, those need to be destroyed for those T cells to destroy them. So they're Y-shaped proteins. They bind to those specific antigens. They help eliminate pathogens. And this also includes like immunoglobulin, so the IgE, IgA, things like that. For the memory cells, I would just think about it. They literally remember specific antigens that they have encountered in the past. So if you were to get an infection, they essentially remember it so that your immune system can respond more rapidly. So that kind of ties into the natural immunity that you receive after getting an infection, right? So with that, you have cell mediated. So that is T cells. Those are created in the bone marrow, but they are matured in the thymus, which we talked about, so T for T, and they are differentiated into different types as well. So you have helper T cells, cytotoxic T cells, and then memory T cells. So with helper T cells, we're talking about CD4 cells. And what's important to know about this is because when we talk about HIV, we're talking about CD4 cells. So we're talking about helper T cells. So this essentially helps with other immune cells by releasing cytokines. So remember those cytokines, they help signal, they help be those messengers for that cell, and then they coordinate and enhance that immune response by being those messengers. So they help in basically activating other immune cells like B cells and cytotoxic T cells to kill the invader. So one thing is, it's like with HIV, we're talking about a patient who ends up having an attack on their CD4 cells. And what's the problem with that is because as cytotoxic T cells, I feel like we all remember those, like those are the killers. But what important, like it's not going to be that helpful to have the cytotoxic T cells if you also don't have helper T cells who help signal those cytokines to tell them, hey, we need to make sure we label this as an invader. We need to be able, like, hey, they're coordinating, they're talking amongst one another, saying, hey, like, this is an invader, we need to go here. So without helper T cells, you're not going to really be able to know which cells are malignant, which cells are pathogen, which invaders are coming in. So things like that. So I would just make sure you know that helper T cells, they help with that immune response. And while T cells are, the cytotoxic T cells are great for killing, you also need those helper T cells to be able to activate those immune responses to signal, to help out and messenger, communicate and messenger signals to those cytotoxic T cells and B cells that, hey, these are invaders. So basically they just help overall. With cytotoxic T cells, these are CD8 cells. So I would just think like the bigger the number, they are able to kill more. I would just think like that. So cytotoxic T cells are the killer cells. So they are able to attack and destroy cells, identify as threats, and they can kill like virus infected cells or cancer cells. But again, it says right here, they directly attack and destroy cells identified as threats, but how are they able to identify it if they don't have any helpers T cells? So the helper T cells help identify that with those cytokines, with those messengers. But if you don't have any helper T cells, the cytotoxic T cells aren't going to be able to know which exact cells are threats to begin with. So that's why it's important to have both. And so for memory T cells, it's the same thing as the B cells one. Basically, they're just able to help remember those specific antigens they've encountered, and they just help the immune response more. So when we're talking about immunodeficiency, we're talking about differences between primary, so something that you are congenitally born with, so what's present at birth, and then secondary, you end up acquiring something, so HIV, cancer, and you see that usually with older patients, right? We talked about that because they're in increased risk of cancer because they have a decreased autoimmune response and your body's not able to detect those malignant cells as fast. And then with HIV, I mean, obviously, with how like high risk sex behaviors can have, if you're having unprotected sex, and which we'll talk about in a second with HIV, that's something that you acquire, right? Something that you end up getting. And same thing with cancer, you're exposed to carcinogens, right? Sometimes genetically, you can have cancer predisposed to you, but some of the time we can see that most cancer cases are tied to like smoking, are tied to smoking, tied to, if you eat, I know other cases are like if you eat too much barbecue food because of all of the smoke and everything from there and the char and everything. So I would just think about it like something you're not supposed to be born with, and then something that somebody wasn't born with, and then secondary, something that you eventually acquire. Okay, so in terms of sepsis, so I know you guys didn't go through everything, so I'm just gonna go through the beginning part here up until like the stages probably before that. But I probably will point out some stuff. So she quizzes you on some stuff. I think I would know some of the things you guys talked about in the past, but really you guys haven't been exposed to this. You've been exposed to it, but I feel like the way that they teach it in third is a little bit more elevated, and then even more in fourth because you start talking about septic shock. So this is just kind of setting, again, like another foundation on top of what you know about infection. So I'll just go through some information and then we'll move on to like the next topic, and then I'll just point out some things that you might need to know. So with sepsis, so what is sepsis? So we know that it is a systemic infection that your body is now having, right? But it's a life-threatening response caused by an infection. And what's the problem with sepsis is it can lead to tissue damage, organ failure, and death, right? So she did ask, I think, a question related to risk factors. So I would kind of just know some of these. And again, it could be different, but you never know, just because I feel like sometimes she doesn't want to ask questions that are too hard on the quizzes, but at the same time, you kind of were exposed to stuff like this before. So the risk factors, things like that, like you kind of do need to know a little bit about the patho in some labs. So I definitely would know a little bit of those risk factors. So mostly seeing people ages 50 years old or older, and that makes sense because again, you have a decreased immune response, right? So eventually sepsis is going to make your body go out of control with the infection. So if you have a decreased immune response, you have just a higher chance of having sepsis, right? So if I get an infection versus like my 80-year-old grandmother who gets an infection, you can kind of guess who's going to have a better immune response, right? So I probably most likely won't end up getting sepsis, but my grandma, she has a couple of like comorbidities and everything, so she probably has a higher chance of getting sepsis, right? And then it's mostly seen in African Americans. I feel like every single risk factor is African American, with the exception of a couple. I think in peds, like most of the time you're talking about white people for some reason who are most predisposed to certain conditions. But yeah, African Americans, I would just know usually it has to just deal with, again, those other comorbidities like hypertension, diabetes, things like that. So other risk factors, again, we talked about age because of that decreased immune response. So chemotherapy, so we know that chemotherapy just helps wipe the immune system, right? Because you're having this cancer in your body, and when we're giving you medicine to help go against that, we're killing off those cells and everything, but we also have to kill off your regular white blood cells as well to make sure they're not cancerous. So basically you don't have any white blood cells in you. So it just wipes your immune system, which makes you, if you end up getting like pneumonia, if you end up getting some type of infection, you are more predisposed to getting sepsis because your body's not able to fight that off. Burns, we talked about this already. So that is, remember, burns is a physical barrier. So it goes under innate, something that you naturally have. And that barriers are the first line of defense. And then the secondary was the inflammatory response. And so genetics, sepsis, I guess if you just are more predisposed, things like that, I think genetics is for everything. Drugs and alcohol, and that's just because the body literally can't recognize foreign invaders when you're drunk, when you are taking drugs, when you're high, things like that. And I literally would think about it like, okay, if you're high, if you're drunk, you're not able to know what's going on. So your body's also not going to be able to know what's going on in case there's an invader. So with pathophysiology, okay, this is what we were talking about earlier with the fluid shifting. So I love talking about this specifically because I feel like this is the only thing that I don't know. I just feel like I've seen it so much in clinic that I'm like, okay, I love talking about it for some reason. But basically, so the first response is activation of the innate immune response, right? So we have that barriers and everything, but now that we're talking about sepsis, we're talking about an infection now that has gotten out of control, but it's more of your body's response has gotten out of control as well. So if we know that with an infection, you have those, let me just read that first before I start explaining and going off. Okay, so your first response of activation is the innate immune response. So response to a non-specific antigen. So you have those barriers, and then your second response, right, that second line that we saw was the inflammatory response, right? So when the body sustains an injury or an infection begins, it leads to tissue damage. Yeah, like I think that makes sense, right? So if you end up getting hurt somewhere, if I end up having an infection on my foot, it's going to be specifically there where my tissues are damaged, right? So this signals harmful invaders to invade the compromised area. So as a defense maneuver, the body increases blood flow to the site through those cytokines and through that inflammatory proteins, causing it to become red and warm while also making the blood vessels leaky, resulting in swelling. Okay, so we talked about this earlier. So with an infection, basically what it's saying is that you have two different responses, and you have more responses as well, but you have two main responses of what's going on with an infection, right? Technically three, but the first one is the vasodilation, right? So all of those, we talked about that, all of those blood vessels are going to dilate. So all of those white blood cells and red blood cells, everything like that is able to travel through that intravascular space, able to travel through those blood tissues, those blood vessels. But the capillary permeability is what allows those fluids and components in those vessels to be able to travel to the actual interstitial space and travel to that tissue site, because if we don't have capillary permeability, they're not able to leak out. So that's why you end up seeing, basically with sepsis, what we're talking about is you end up seeing the body's response getting too overworked. So if we're talking about sepsis now, okay, so you had an infection, now it's getting worse. So your regular body's response was to have vasodilation and to have increased capillary permeability, but now with sepsis, because it is a systemic infection, because maybe this person's immunocompromised, maybe they're older, their immune response is not able to work as hard, it's going to overwork, and your body's response is going to be way more than it should be. So it's going to vasodilate your vessels a lot, So if we know that the vasodilation increases the blood flow to that site, you're going to end up seeing a decrease in blood pressure only because they're not constricting, they're becoming bigger. So, right, I would just think about it like if I had like a straw, right, and I was pushing water through it. If I were to have that hose or that straw become smaller, the pressure through it would be a lot higher, right? But if it's wider, the pressure through it's going to be a lot slower and a lot lower. So I would just think about it as like usually with sepsis, what ends up happening is that your blood pressure ends up going so hypotensive because you're vasodilating your vessels so much to the point where it just can't stop, right? So you, in a regular infection, you would just vasodilate, but now with sepsis, it's vasodilating to the point where you literally can't control that blood pressure anymore and you can't stop. And then the other response, so the increased capillary permeability, which allows those components in the vessels to go through to those tissues into that interstitial space and help leak. The problem is now you get into that third spacing because all of that intravascular fluid that was in your vessels are now going through that capillary wall and everything, and now they're going into your interstitial space. But now so much of that fluid is leaking out that they're not able to come back in. It's too much fluid. That's why you're hypotensive, and that's why you see all of that fluid end up in that interstitial space, and you see them become edematous, right? So basically, it's just too much. And then the third body's response to this infection, in a general sense, is those clotting factors, right? So platelets, everything like that. So basically, platelets, I would just think about it like platelets literally stop. Like obviously, if we have like a pulmonary embolism, a thrombosis, and like let's say I have it in my arm again, I end up having like a clot in my arm. That's going to stop all of the blood flow from going to my site, right? So it's the same thing with an infection. Your body wants to have those clotting factors so it literally can stop the infection from going somewhere else. But the problem is with sepsis, it does it too much. It's clotting too much. So obviously we know if you're clotting too much, you're gonna literally stop if I have a clot here and I have sepsis and let's say it keeps growing and growing and growing, it's literally gonna stop the rest of my arm from being oxygenated, which is not a good thing, right? And then it would go the same for the rest of the body. So we know there are vessels throughout the rest of our body. If I have a clot somewhere that's close to my heart, close to my lungs will not get oxygenated. My heart won't get oxygenated. So that's why with sepsis, you end up seeing organ dysfunction. So just remember those three things. So vasodilation, capillary permeability, and clotting. So with sepsis, they all increase to the max to the point where your body can come back from it. And you end up having more destruction as a whole because there's no oxygenation, you're leaking too much, and then your blood pressure is becoming super low. So you're not having proper circulation to begin with. So I hope that makes a little bit of sense, but I'll go ahead and continue reading it. So I'll start again from the white blood cells. So the white blood cells rush to the scene via the increased blood circulation, so the vasodilation, and they migrate into the tissues. So they migrate into the tissues by the capillary permeability, being able to go through those walls to combat the germs to that tissue site. So these cells, which are like so we're talking about macrophages because they eat up those invaders, are like a cleanup crew. They devour the unwelcome bacteria and those viruses. So to prevent the spread of infection, additionally, the body initiates clotting, but this inadvertently leads to the formation of microemboli. So that's what we're talking about. But the problem with it, with sepsis, is that it leads to those microemboli, which basically leads to tiny blockages in the blood vessels, right? So that's why you end up seeing it become painful because you're not having oxygenation to that site. And then you might see discharge, like let's say if I were to get a cut or anything, you might see discharge, clear fluid, right? And that's a good thing because that's basically showing you that your immune cells are reacting to those pathogens. So additionally, the whole body may react to this intense skirmish by developing a fever, experiencing malaise or discomfort and chills. So basically this is a sign that the body's all-out effort to fight invaders is working, and then the redness, warmth, swelling, and pain all manifest because of that. So with sepsis, this basically just happens when the body's defense against an infection gets out of control. So what we talked about. So instead of just fighting the infection where it started with the vasodilation, with the capillary permeability, with the clotting, now it's causing the chemicals in the blood basically cause inflammation all over the body. Now you have widespread inflammations that can make the blood vessels widen too much. Now your capillary permeability is too much, so your vessels are becoming too leaky. So that's where the third spacing occurs. So all of that fluid, those components in the vessels are now going to that interstitial space. They're becoming too leaky, too permeable. So now you're having all of that components in there go out. And now you have third spacing. And because all of those components are going out, they're not remaining in that actual vessel. So that's where you see the drop of blood pressure. And remember, when we're talking about blood pressure, we're talking about you're taking it from those actual arteries, those actual vessels, like you're taking a blood pressure through that. And that's what ends up causing swelling, just because all of that third spacing, it's not in the vessels anymore, it's actually out in the outer space. So at the same time, again, we know that another body's response is to clot to help literally stop that infection from going through. But basically the blood starts to clot more than usual. And then that creates the blockages, and that creates that oxygen from getting to the rest of the organs. So with combination of all of those three things, you end up seeing cases of like septic shock. You end up seeing the complications that come from this because you don't have oxygenation, you don't have proper circulation, in which just remember, like in that intravascular space, one of those things are red blood cells. What do red blood cells carry? They carry oxygen. Remember, like the hemoglobin, the four things there. So just remember that for sure. So yeah, oxygenation and perfusion is being decreased to the max, just because all of your other fluids and components are just going out to your interstitial space, your edematous. And then yeah, so it's kind of just out of control, and that's what causes all of these things to happen. So I hope that kind of makes sense. So with the stages, I won't go ahead and explain some of this stuff because I think you'll go over it in class. So I would just know for this stuff, for manifestations and cues, early, so hyperdynamic or warm. So in case you haven't talked about this already, I would just think about it like when it's warm outside, or let's say you're exercising, you're going to have tachycardia, bound pulses, you're going to be warm, flushing, you're going to have a fever. Your blood pressure will be normal, just because I would just think about it like it's still early, right? So we haven't really third spaced yet, but your body's still trying to compromise. It's still trying to be compensated. So you're still going to have like a heart rate that's higher because it's trying to circulate all of the blood throughout your body. You're going to have bounding pulses. You're going to be warm because you're starting to third space, and then you're going to have decreased perfusion, which you start seeing already, right? So with late hypodynamic or cold, I just think about it like cold. So you're still going to have tachycardia. And I would just think about it like, regardless if it's late or early, your body and your heart is literally trying to circulate as much as it can that blood and those components to the rest of your organs. So with your heart is literally going to be increasing its heart rate, so it can try to do that. But you're going to have weak and thready pulses. You're going to have cool, pale skin, hypothermia. Your blood pressure still remains low. And again, you're still having decreased O2 to the tissue, so decreased perfusion. So you're still going to see the loss of consciousness, but it's going to be further more to the point where you're going to get a coma, you're going to be super tired, and then you're going to have anuria. So you're not going to be able to use the bathroom. So I would just think about it like early it's warm, and then late it gets cold, right? So it kind of works out since we live in California. But the only difference is your blood pressure for early can still be normal because it's still early, and then with late your blood pressure is going to be low, and then with tachycardia it's going to be for both of them. For labs and diagnostics, so we think we all know that you should be getting culture so it can show the bacteria. We all know that white blood cells indicates an infection, but we talked about earlier, those neutrophils are able to kind of detect a new or an older infection depending on if they're like the bands. So again, neutrophils are the first white blood cells that go to that site. And then for the bands, those are immature cells. So if they keep being made and you see that they're high, then that means that there is some type of infection going on recently or previously, just because they're immature, and then your body's trying to make new neutrophils as it keeps going and keeps having this infection. So with the lactic acid, so procalcitonin is technically a better indicator, but the reason why we always like run up lactic acids in the hospital settings is just because they're cheaper. So unfortunately, capitalism gets the best of everybody. But I would just say that usually calcitonin is the best indicator of infection, because with lactic acid, your lactic acid can be high for a multitude of reasons, right? But lactic acid will still be high, so just know that. So it just builds up in the blood where oxygen levels are low, as it's a way for the body to get energy. And this is through anaerobic metabolism, and tissues aren't able to get enough oxygenation. So the way that lactic acid works is, if you kind of remember it, like if you're working out, right? So when you're working out too much, you end up feeling like your muscles are getting sore and they start burning. And yeah, like that does have to do with the lactic acid buildup and everything. So that's just because your cells are overworking to the point where they need energy. And so what ends up happening with an infection, so your cells are overworking itself, right? So they're trying to fight off this infection, everything like that, but they need the energy. but you don't have enough energy, you don't have enough with your body's response. So through anaerobic metabolism, they're able to get their oxygen through that, and then as a result, the lactic acid ends up producing itself, and then it ends up going into your bloodstream and everything like that. So it ends up being produced by all these cells and just put out. So I would just think about like it builds up in those muscles, and then like it's just like when you're working out, they build up in those muscles and they come out, right? So lactic acid should be high there. With procalcitonin, it's a better indicator of infection. So she might ask that, because those two things you should kind of already start knowing. And then normally they exist in low levels of blood and rise when serious infection, but usually this also indicates more of a bacterial infection for procalcitonin, but it is the best indicator. So with organ function, you are going to see cardiac enzymes be increased. So if we know that with sepsis, you're going to have that perfusion be low, because not only are you third spacing on all those components, like your red blood cells are coming out into your interstitial fluid, not remaining in the intravascular space. And we know that those vessels go to your heart, they go to your lungs, they go to your body, they go to your brain. Like all of those things are important, right? So that's why you see a loss of consciousness. That's why you see tachycardia, because your heart's trying to overwork. That's why you see kidney dysfunction, because your kidneys are being perfused. So literally it is a systemic thing. So if we're talking about looking at organ function, the cardiac enzymes, so CPK and troponin, you're going to be able to see those be elevated because they're working harder, right? So we know liver, so LFTs, AST and ALT, we know those are going to be out of normal range because there's some dysfunction there. Kidneys, same thing, BUN, creatinine, EGFR, those things. And also another thing that she could ask in terms of BUN and creatinine is if they're elevated, what that means too is that the patient's dehydrated, right? So they're probably not drinking fluids anyways, and because they're third spacing, they are dehydrated to begin with. So they're not having proper circulation perfusion. In addition, they're not going to be having good hydration status because of those fluids being out of their vessels and everything. So that's why we give them IV fluids to try to help against that. But I would just say for the kidneys, yes, it could just mean that they're having decreased circulation, but also like with a high BUN and creatinine, it could also mean that they are dehydrated. So just note that. And then with pancreas, we're talking about those amylase, lipase, things like that. With the blood, you see more clotting factors, remember? So we're talking about with the patho, we're talking about vasodilation, permeability, and we're talking about clotting factors. So with PT, PTT, and INR, we're literally talking about clotting time. How long does it take the body to clot? So we're going to see it's going to be doing it a lot faster. And then manifestation. So we talked about that. And then sequential organ failure assessment. This is just, I don't even think she asked us about this, and I think she told us that we should know it. But basically, this is an assessment when a person has a presence of sepsis, and basically if they have a higher score, higher mortality. So higher is bad, but don't feel like you have to know that. Again, I'm just going through this information, but I'll probably go through it more in depth next week or whenever we meet again. And for the management, you should kind of know this, and I feel like it is kind of implied. And you just think about it, right? If your whole body is reacting in this certain way, what are we going to do to support those organs? So like if your lungs aren't being perfused enough, you're not getting oxygen to your lungs because of that circulation, because of that third spacing, we're probably going to put them on a vent, right? And probably they're going to probably need some type of oxygen anyways because their body's overworking. And then dialysis, right? So for your kidneys, they're not working. Insulin, your pancreas as well. So everything that you can think of for organ support you will need, right? And then for vasopressors, this is just going to be able to help with that blood pressure to be increased, right? Because of the vasodilation, we're having a decrease in blood pressure because it's not as tighter, it's literally wide. And then you're gonna have inotropes, so like digoxin, and that's gonna help have the heart beat better, maintain that blood pressure, things like that. So again, we're going to be giving fluid and blood products so that the organs can get proper O2, because again, they're in that intravascular space, but now they're going to the interstitial space. Antibiotics, of course. And then it just says the PPIs, so like pantoprazole, things like that, just because it helps with GI ulceration or stress ulcers that you might get. But really, what is the first line of therapy that we always do for every single patient? It's going to be prevention. And so she might ask a question about that. I remember the question was like, what's like the first line of therapy we always come across, right? And don't get that confused with immunity. We're talking about like first line of therapies for prevention, right? So that's always going to be prevention. We always want to prevent this from happening. So if they're able to wash their hands, use aseptic technique. If they're on a vent, you want to make sure you're doing that properly, giving them proper mouth care because they have an infection again. So yeah, you don't have to know this like a lot. I don't even think she'll ask about this. I think the only thing she'll probably ask is, yeah, like what's the first line of therapy that you see? Prevention. So for core measures, she might ask this because I feel like you should know this. It's completed in 1 to 3 hours, and don't feel bad if like I might say things like, "Oh, you should know this," but don't feel bad. Like I still have to sometimes look back and be like, "Oh yeah, that's right." So just make sure like you're looking at it. So completed in 1 to 3 hours, and then completed in 6 hours. But really, we're just doing this as a whole when a person comes in with sepsis. So we measure that lactate level, right? We're doing that even though procalcitonin is better. We're still going to look at their lactic acid first. And then we do blood cultures prior to antibiotics. Why? So that we can see what specific antibiotic fights that infection the best, right? And we remember that for micro. We administer broad spectrum antibiotics. So just be careful because sometimes she likes to say we administer like antibiotics, which it's not wrong, but it has to say broad spectrum. So just make sure you're paying attention to that for sure. And then we administer 30 mLs kg crystalloids for hypotension, or if their lactic acid is above 4. And so, yeah, it's just kind of memorizing that one, right? So we're just going to be giving IV fluids. That's what I would just think. And then time of presentation. This is just kind of an extra thing I think she added in here, but time of presentation, right? So how much time does it take for them to be triaged in the emergency department? So of course we want to be doing this within a specific amount of time, but I don't even think that was an option that she gave us. In the 6 hours, we're going to give vasopressors, right? So we can increase that blood pressure if that hypotension wasn't already resolved by the fluids you were giving earlier, so the 30 mLs, right? So we're not just going to start off by giving vasopressors. We're going to try to give them IV fluids so there's more of those fluids in that intravascular space, and then we're going to go ahead and give vasopressors if that still isn't working, and all of that IV fluids just end up keep coming out of those vessels because of the permeability. Then we'll go ahead and give vasopressors to help with that. And we'll also do that to maintain an MAP, which you guys will go over. You guys maybe have already gone over that. And then we're going to continue to document those findings of volume status, tissue perfusion, right? So we're going to keep looking at their vital signs. If their blood pressure is still low, how is their heart rate looking like? Their skin findings, are they still warm? Are they cold? Those pulses, cap refill, how's the perfusion looking? So yeah, and then we're going to measure that lactic level again after everything's done. And then some new guidelines if sepsis is so either way, antibiotics should be administered within the first hour. Like that's still something that we need to do. And then with sepsis, if it's not definite, then we definitely do need to administer antibiotics within 3 hours. So I would just know you need to administer antibiotics, but specifically to begin with, you need to be administering broad spectrum antibiotics. So with septic shock and DIC, MODS, and ARDS, again, I won't be going into this in depth. I feel like I am, but I would just know, maybe, I don't think she'll ask you about this because you literally haven't learned this yet. If we're talking about those different factors, like with the vasodilation, permeability, and the clotting, septic shock is now we're talking about almost every single thing is happening. So your body's going into shock, it's overworking itself. But with DIC, we're talking specifically about clotting, right? Because it says coagulopathy. So this is a hematological disorder associated with enhanced coagulation, which leads to those blockages and prevent blood from reaching those vital organs. So just remember, again, we're talking about those clotting factors to the point where they are so increased, they are literally cutting off your blood circulation. But at the same time, the excessive clotting depletes the platelets and clotting factors. So as a result, sometimes your body knows I am making too much clotting, I am making too much clotting factors, I'm making too many platelets. So as a result, it's going to stop. And then that also can lead to a risk of severe bleeding, right? Because if you don't have any of that to stop, if let's say you get a cut or anything like that, you don't have any platelets or clotting factors to stop that bleed, then you're going to keep bleeding out. So really, it can be like it can be severe in a way where like you're getting a clot and you're having decreased perfusion, and then it can be the opposite side of the spectrum where your body's going to stop doing it because it knows it's doing it too much, and then it literally will stop producing clots and platelets, so that when you get a bleed or you get a cut, you're not going to stop you're not going to stop bleeding. Okay, and then with mods, this makes sense. Okay, so if we're talking about perfusion meaning we're talking about circulation. That's what we're talking about, blood circulation. So that intravascular space, all those components are going to, so my vessels, they're right now, they're all going to my heart, my lungs, everything like that. So if we know that with sepsis, you're not going to be having all of that proper perfusion, because all of that components are going out into that interstitial space because of the permeability. You're not having proper perfusion, and RBCs, remember O2, they carry the O2 with the hemoglobin. They're not being able to bring to those organs, so you're not perfusing. So basically, multiple organ dysfunction syndrome literally means what it says. you're going to see those kidneys, you're going to see those liver labs, things like that be abnormal. So just kind of, it's literally what it's called. And then acute respiratory distress syndrome, same thing. Basically, because of that fluids shifting, because of that perfusion, you're not getting as much oxygenation. I mean, in terms of the perfusion to your lungs, but more specifically because of how inflamed you are and because of all of the third spacing that's going on, the fluid has to go somewhere, right? So as much as you can be edematous, at a certain point, the fluid that keeps coming out needs to go back somewhere. So it's going to go into your lungs. It's going to go into your heart. It's going to go into these places. But specifically with acute respiratory distress syndrome, the problem with that is if it goes into your lungs and then you end up having fluid literally go into your lung air sacs, that's going to make it difficult to breathe, right? And that's going to kill you first. Remember, like ABC. So that obviously isn't a good thing. So really, it's just that fluid shifting, going to the max again, and then you end up, that fluid has to go somewhere. It goes to your lungs. Too much fluid in your lungs, can't breathe. So yeah. And then obviously death, very sad, but I was gonna say, like, you know, that's with everything. Okay, so with HIV and lupus, we can go over it a bit. You guys haven't learned about it, so I don't think that they will ask you these questions just because it wouldn't make much sense because you haven't been exposed to it yet, right? So I'll just go through some of the information. And then if you guys have questions about it, like next week or anything after you go through it, then we can go through that together. So disease, it's basically a disease caused by a human immunodeficiency virus. So that's literally what it stands for, where it essentially depletes helper T cells. So we're talking about CD4 cells, remember? So CD4 are the helpers, CD8s were the cytotoxics. So remember, helpers help those cytokines, which help be messengers for other cells to say like, hey, these are the invaders, remember? And then those cytotoxic T cells can come and kill it. And it also depletes macrophages. So those macrophages, remember, they eat those invaders, they eat those pathogens. So without helper T cells, you essentially don't have you don't have an immune response to be able to identify those pathogens that are coming in. So the highest rates of HIV and AIDS is usually seen through gay and African American men. So remember, just African American is just a common race that we see. And then with gay men, we can obviously see that's because of the increased like sex behaviors that they can have just due to unprotected sex, and or if they have multiple sex partners. I will say I do think I don't think she asked questions about this, but I think I feel like sometimes they talk about like the social determinants of health, of health. And one thing about like gay and African American men, yeah, like we do see increased like risk behaviors in terms of them having sex and unprotected sex, multiple sex partners, but that also is attributed to a lot of different things, right? So there was a lot of stigma about it, obviously, like I think we all remember, like in the 70s and 80s. So a lot of the time people wouldn't go get tested because they were afraid of the response of what's going to happen to them after, right? And I think a lot of people ended up passing away, also because we didn't have a lot of advancements of what we do now. But the mortality was a lot higher because of that, because of like the socioeconomic state that a lot of people were in, and also like the stigma around it. So a lot of people didn't want to go tell anybody like I have HIV. So the problem is that what ended up spreading all of this was because nobody wants to say anything to anybody else. And nobody wants to really get the help. And again, with HIV, and which we'll talk about in a second, you don't know if you have HIV until a little bit in. So that's what made it super difficult. So yeah. In terms of transmission, I think we know like it's transmitted through bodily fluids, blood, semen, vaginal fluids, breastfeeding, etc., anything like that. So that's why usually the mom who's pregnant, we want to know if you have HIV. So the problem with HIV, so in this day and age, okay, and even before, HIV is a bad thing because it takes away all of your helper T cells. But the problem is that you don't necessarily die because of HIV. You die from the infection that you end up getting, and you just also have HIV, right? So because all of your helper T cells are gone, they're not able to identify those pathogens. Basically what ends up happening is you end up getting like pneumonia, and you die because you have pneumonia, but also it didn't help because you had HIV and everything, right? So it's not necessarily that you're dying from HIV or AIDS, it's just more of because you end up getting an infection and you don't have any helper T cells to help identify those pathogens. So again, people don't necessarily die of HIV, but of the infections that occur after, and also because they're immunocompromised now, right? So the pathophysiology, and so to kind of explain this, basically what happens is the HIV, once it is transmitted through those bodily fluids, they go inside the person's body, they invade those CD4 immune cells, so the helper T cells, but they literally change its RNA. So if you remember from like AMP, RNA, DNA, they basically change its DNA to where instead of having the cell like be destroyed or anything. Like literally change it into like HIV particles. They literally change the CD4 cells to being more HIV cells, kind of is a way to think about it. So this ends up leading to a loss of immune cells. So as a result, the body's ability to fight the infections weakens because you don't have any more, and the acute viral infection occurs, and there's an increase in HIV viral load. So how much HIV is in the blood. So that is something that you do have to know for viral load. This is how much HIV is actually within the blood. So viral load, right? So I would just think about it like exactly what it says, viral load, how much of it is within that blood itself. So within several weeks, it's followed by seroconversion. So that is a big word she likes to use. And that's basically where HIV antibodies become detectable. So like I was saying, at first, you're not going to be detectable because it just starts converting that RNA into DNA. So it's changing that. But then to a certain point, you're going to end up seeing the acute viral infection, and then the HIV viral load will end up increasing because if it keeps changing, your HIV comes into your body, it keeps changing those CD4 cells. Eventually, it will keep changing all of your cells to the point where it becomes a high viral load because now you're seeing a lot more HIV in the body and in the bloodstream. And then eventually the seroconversion, that specific word just means is now it's becoming detectable. And that's what makes a person HIV positive. So one thing that she does talk about is just because a patient's like viral load is low doesn't mean that they aren't HIV positive. Like you can still have a low viral load and still be HIV positive. So it's kind of like remission, like with cancer, and which she talks about as well. Just because you're in remission doesn't mean that you're necessarily cured from cancer, right? That just it can come back and come back higher. So just to keep that in mind, just know that because she could always ask a question about that, and I'm pretty sure she did. But for the quiz, maybe not. This is more of like an exam thing. So there's different types of stages in which we can go over like next week. So asymptomatic, so literally what it's talking about, it's your immune system still has control, but eventually your viral load is going to, your CD4 has increased to normal, but the viral load drops, so your immune system's kind of fighting it, but eventually your viral load will increase, so there's more HIV in your blood now, and then your CD4 will decrease. So at first it's like, okay, but then it gets bad. Okay, and then for symptomatic, so now you actually have symptoms. So the viral replication is slowly lost. So the control over that is slowly lost. Your immune system's not able to help fight that anymore. And then your signs and symptoms will start to develop. Your CD4 decreases faster, and then the viral replication keeps going. And then in terms of AIDS, this is the final stage. So it's not like HIV and AIDS are two different things. AIDS is just the final stage of HIV. So the CD4 continues to decrease, but specifically, she does mention on the exam, I think, it is specifically under 200. And this is where the immune system is less able to fight off infections and has lost control of the HIV. So diagnostics and labs, again, you don't need to know this for the quiz, but just to go over it. To diagnose HIV, you do rapid tests of ELISA screening tests and repeat it every 3 to 6 months because of detectable levels. And what we're talking about is it's in like the movies when they have like the little, there's always like a scientist in a lab, and they have like the little square and you see the little, there's always like squeezing like the little drip dropper, and they're just squeezing little drops into tubes. It's basically kind of what it is. And basically if it changes color, I believe, or if they find that it's detectable, that's how they can detect HIV. But with an ELISA, it has to be confirmed with a Western blot test as well. So you don't necessarily need to know what they are. You just need to know they need to be confirmed. That after you do one, you have to do the other. So with AIDS, again, how do we know? Well, of course, we're going to check the CD4 count if it's under 200. And then also if they end up getting an AIDS defining illness, which we'll talk about. So again, you're not going to necessarily die because of HIV or AIDS. You're going to die because of the fact you don't have any helper T cells, and now you get an infection and your body's not able to respond against that. So again, you can usually look at the viral load for infants. That's another thing that goes on, right? Because sometimes mothers don't tell us if they have HIV. You look at patients with CD4 and viral load count every 3 to 6 months. That makes sense because of course you have to look at it. And then you'll do TB surveillance, right? Because of infections. So with the other ones, I mean, we could talk about it next time, but the biggest ones that we talk about is PCP, so pneumonia, basically. I'm not going to say the whole name and butcher it, but inflammation and fluid accumulation in the lungs. So basically you're getting pneumonia. TB, yeah, we all know what that is. So routinely done. You should get a test done every 6 months. So I would just think about it like, for us, we have to get a test done like every single year for nursing school, which is a little bit ridiculous, but because we have to like pay for it sometimes. But basically, like as students, we have to get it just because I think it makes sense in theory because, you know, we're stressed out, we have things going on, we're exposed to a lot of different patients. So we end up having a higher risk of getting infections and TBs. And a lot of the time I've gotten sick throughout school because you're going through a lot, right? You're stressed out, you're not getting enough sleep, you're not eating as well. So things like that. So just think about like with an HIV patient who's obviously immunocompromised, you're wanting to get the routine check done almost every 6 months, like very frequently. So with the other ones, I mean, we'll talk about that stuff, but she won't ask about this. I feel like those two were the main ones. I feel like she does talk about toxoplasmosis, and I think if we remember that for micro, this is the cat feces one. So of course we don't want any pregnant woman to be touching cat feces or the litter because it can expose them to this parasite, right? So it's the same thing with immunocompromised people. So whether you're in cancer, whether you have cancer, you're going through chemo, whether you have HIV, just don't touch it, right? And so to kind of go in for, I won't really go too much into this because you guys haven't gotten to it, but basically, those are just some medications. She doesn't really ask, I feel like on quizzes or exams, like any of like the treatment things. I feel like she only asked a couple of questions. And in fact, I feel like she asked IV fluids, which we'll talk about before an exam because there's some IV fluids you specifically give to a septic patient. But with like HIV and everything, I feel like she didn't really ask about this. I think the only thing she asked about is like make sure you're able to look at the medication and like kind of know, and it makes sense because I just think like antiretroviral, like they all start with like B's and they kind of look like viral, and then the last one's just like an outsider, so it kind of just looks weird. But yeah, so HAART is basically just highly active antiretroviral therapy. So you can make the viral load become undetectable at some point. So we know that the viral load is how much HIV is in the blood. But again, just because you have a low viral load doesn't mean you don't have HIV, right? But we can make it to the point where they're taking their medications to where their viral load is so low, which is a good thing because we have less HIV in the blood and we're able to have more CD4 cells. So they're able to help detect those pathogens, those cytokines. They're able to help get those messengers and that communication between the cells. But I will just say a lot of people don't end up having good or undetectable viral loads because of the fact that they're just not compliant. So usually with HAART, you can just give like 3 drugs from 2 of the 6 classes of drugs, right? So you just give more basically, so it can end up hitting those multiple stages of the HIV replication cycle, and which she'll go over, but I don't think you have to know that. And then for side effects, I mean, they're all just like short-term side effects like nausea, vomiting, diarrhea, things like that. Whereas long-term effects are going to be like the long-term things that you're going to see. So like kidney dysfunction, liver dysfunction, diabetes, heart disease, hyperlipidemia, osteoporosis, nervous system. So literally long-term things. So I think those are easy to differentiate against. Is just because some of them it's like nausea, vomiting, diarrhea. Like we all sometimes get that, right? Whereas long-term, like those are things that are different, and that's unfortunately just the problem with these medications. Just because eventually because they're already immunocompromised, and because we're giving them a bunch of different therapies and medications, it can also impact them that way. So again, I said this already, but even if the viral load is low, so it's not detectable, the patient needs to stay on those meds due to the latent HIV reservoir, right? Because they're still going to be in there, right? It's not just like if you're low, it's just like how a patient says, like, well, I'm taking metoprolol, right, which we know is an antihypertensive, and my blood pressure is low now. So can I stop taking the medication? It's like, well, no, because your medication is what's helping you keep your blood pressure low. So it's the same exact thing with HAART and with this medication therapy. Just because your viral load is low doesn't mean you can stop just taking your meds. That's what's helping you keep your viral load low. Additionally, there's a latent HIV reservoir. So in the replication cycle, it can still stay, the HIV will still be in there, and it can still end up changing that RNA into DNA and converting those CD4 cells. So yeah, and then other things, analgesics, right? The problem with analgesics is sometimes, NSAIDs, they work on the GI system. They can be metabolized through, like with ibuprofen, they could be metabolized through like your liver, your kidneys, everything like that can still be affected. So just keep that in mind with giving analgesics. Nutritional support, right? That makes sense because their immune system's not able to be well enough on their own. So you have to make sure they're getting enough nutrition. Most of them end up losing weight as well. So immunizations, that's another thing. Get those immunizations. So no live vaccines, which I have there, which makes sense because I think that we know that for any immunocompromised patient. And then with Truvada, again, she won't know this. I'm just going over it, but she won't ask you about this, but it won't help to kind of go over this before your guys' class. So PrEP, that's basically what it is. I think you've heard like Truvada commercials before. PrEP is basically reducing the risk of requiring HIV. So this is given to a serodiscordant couple. I don't know if I'm saying that right, but What is serodiscordant couple? And she will probably ask this. I think this is an exam question, not a quiz question. So serodiscordant couple, what that means is one partner has HIV, but the other partner does not have symptoms of HIV. So that doesn't necessarily mean that they don't have HIV, but they don't have symptoms yet. So it is possible that they don't have it, but basically one person has it, one person don't. So if you give Truvada, that can help prevent that person from end up getting HIV or requiring HIV. So with management, again, we wash our hands, no fruits and vegetables, and that goes with cancer as well, right? Because I think I just use the logic of, when we come home from the grocery store, we wash our fruits and vegetables, at least we should. And because we know that they have bacteria on it, we know that everybody's been touching it, things like that, right? So if a person's already immunocompromised, let's not go ahead and give those fruits and vegetables. And then do not remove the cat litter by itself, the toxoplasmosis, right? So nobody should be touching it. Wash and bleach the toothbrush in the dishwasher for 1 week. The logic with that, they put a lot of that stuff, like you should wash your stuff in the dishwasher. I know for like OB and P, it's like you should wash your water bottle, your baby bottle in the dishwasher. And the reason why is because I believe it's more likely to kill bacteria off. And make sure you're using bleach for that as well. But just things to know. And then no sick people, I think we know that. So if you're going around people, just make sure you're wearing masks, make sure you're not in large groups. And then another thing she does mention, this could be a quiz question because I can see her asking this, but I don't think it will be. It's more of an exam question. Reverse precautions is to protect the patient. So when we have a precaution sign, things like that, most of the time it is to protect yourself, but specifically with HIV patients, when we're talking about reverse precautions, we're talking about you're wanting to protect the HIV patient. So the question could be like a nurse, a charge nurse is asking, or let's think, a preceptor is asking their nursing student if reverse precautions is to protect the patient, to protect family members, to protect herself, or to protect, I don't know, other practitioners, right? And so two of the answers are a lot alike. The practitioners and the nurse, those are a lot of almost similar questions, but our answers, but the answer would be to protect the patient, right? Because those are reverse precautions. They're checking to protect that specific patient. So there's no visitors allowed in the room, no kids, because they carry sickness very easily. No flowers or plants in the patient's room. Same thing with the fruits and the vegetables, right? They have a higher chance of finding bacteria, parasites, things like that. So yeah, okay. Now going into lupus, same thing. I'll just try to go through it really quickly. Lupus, it's an autoimmune disease. I think the one person at the celebrity world that we think we all know who has it is Selena Gomez. And the only reason why I think about it is because a lot of people have been giving her shade about how she looks in terms of like her face. But the one thing that you will have is fluid shifting, and you will have like edematous look on your face, like almost like moon face sometimes. And because of all of the medications you're giving, and because really it affects your kidneys a lot, with lupus, you're going to have a lot of that extra fluid and everything like that. So really what lupus is just an autoimmune disease that affects connective tissue. So I feel like she highlighted it on that. And basically it's an altered immune system where antibody formation and immune complexes deposited in the tissue. So literally it's your autoimmune system is almost attacking itself. And so usually it's associated with females between 16 to 55, and again, that's associated with hormone levels and everything. And then Hispanic and African American, again, there's no cure for it. The patho kind of is more tied to just like general inflammation. So that can be caused through pregnancy, obviously, sunlight, because let's say like you're getting a sunburn, right? So as a result, again, like from that innate immunity, your second line of response is going to be inflammation. So you're going to see illnesses, right? You end up getting inflammation, major surgeries, inflammation again, exposure to silica dust. That one's super specific, but I would just think about it like dust, allergies, things like that. And also certain medications can have inflammation side effects. So for etiology, genetic influence or environmental, right? So again, talking about those environments, so kind of tying into the patho for that. And then obviously if you just have more of a genetic predisposition of getting lupus. So I know some people in my family have lupus, but we have a lot of comorbidities. So hopefully I don't end up getting anything. But yeah, just kind of keep in mind genetics with everything. So classifications of lupus. So you end up seeing 3 different types, and I feel like it is pretty easy to know them if you just listen to the name. So discoid just infects the skin. So one of the biggest things, and she will ask this on an exam at least, or you should probably just know this in a general sense, the biggest sign and symptoms of lupus is a butterfly rash over the nose and over the cheeks. And then a systemic classification of lupus is that, again, we know that affects the connective tissues, but it ends up also affecting your organ system. So that can lead to organ failure. So systemic meaning like everything, right? So I would just think about it like that. And then drug induced means exactly what it says. So you end up getting symptoms because you're taking a certain drug. And then once you stop taking that drug, you stop having it. And so those are just some medications that usually end up giving drug induced lupus. But most of the time, I feel like she's just going to ask like the butterfly rash over the nose and cheeks. Like if a patient comes in with butterfly rash over the nose and cheeks, what does she have? And it's like, you only talked about like 4 things in this lecture. So it's like lupus, like HIV, things like that. So it's like, there's only so many different options. And that one sounds the most like weirdest kind of thing, doesn't really tie in with HIV, doesn't really tie in with cancer, doesn't tie in with sepsis. So it's going to be lupus. So diagnostics, you must have at least 4 of these, but really the big one she hits on is ANA, so anti-nuclear antibody. So that's just the most likely to diagnose. So it's just a specific antibody, because remember, this is the immune system attacking itself. So it has an antibody that is going to be high. And then with ESR and CRP, those are just inflammation markers. So if you end up having sepsis, you also can see those be increased as well. CBC, anemia, thrombocytopenia, leukopenia, all of them are low because again, you're having a decreased immune response. For urinalysis, you see proteins and more in the urine as well, and that's related to the kidney function, right? So basically, because of the fact that your kidneys aren't able to filter everything out, your kidneys are usually the most affected organ for lupus, so that's why you end up seeing the proteins there. And then for BUN and creatinine, again, because of the kidney function, and then sometimes the syphilis can give a false positive. She doesn't ask you about that, but just in case, just to know. And then for the other manifestations, there's fever, malaise, alopecia, anorexia, weight loss, anemia, joint pain, photosensitivity. I feel like the biggest ones were photosensitivity, and the rest you can kind of just guess because of a decreased immune response, right? For this medication, the hydroxychloroquine, that's an anti-malarial drug. The biggest thing with that she does test on is, I don't think she asked this on the quiz, but retinal toxicity. So you will need to have them get biannual eye exams. So just make sure that is the medication you're giving, and that's just to help with the arthritis, the joint pain that they're having, and the skin manifestations they're having with the butterfly rash. But the problem with this drug is you will need biannual eye exams because of the retinal toxicity. So that's like the biggest thing she hits on for this. And then same thing with NSAIDs. You're going to give NSAIDs for inflammation, right? Non-inflammatory, anti-inflammatory drugs. So aspirin, ibuprofen, naproxen are all NSAIDs, and they help with the pain, right? But they also help with inflammation. So GI effects and then the kidney damage that comes from the NSAIDs is another thing you want to worry about, just because, and she can ask this too on like an exam, just because if your kidneys are being affected with lupus and you're giving NSAIDs, you probably just want to either educate the patient, you want to just bring it up and to the provider if they're coming up with like a BUN, EGFR, creatinine's affected, things like that. Okay, so with the glucocorticosteroids, so steroids, just the zones, right? So they help with joint pain, they help with the rash, help with the inflammation. So again, we're just worried about some of those side effects. So you guys remember the GHATs, the accessibility to infection, right? They're at a higher risk of getting an infection, electrolyte imbalance, hunger, insomnia. And with the infection, so if they're at an increased risk of infection and they're already immunocompromised, obviously that's something we want to worry about. And then with the last medication, which is belimumab, I can't even say it. It works by inhibiting a protein. You don't really have to know that, but basically it allows the B cells, which are often overactive because they're trying to produce autoantibodies to attack the body's own tissues. So B cells, they make antibodies, remember, with the plasma cells and everything. So we know that autoantibodies are bad, right? So autoantibodies, they attack the own body's tissues. So basically this medication just helps to stop those overactive B cells as a whole. So surgery, you can get kidneys because again, your kidneys are most impacted. You're going to have joint pain and everything, so you can get joint replacements. Complications, kidneys, CNS, lungs, heart, infection, cancer, vascular necrosis, pregnancy complications. So obviously all kind of just everything is what I would say for that. Management, collaborate with your PT about joint pain, dietitian, pharmacy to manage those medications with the kidney dysfunction with NSAIDs. Same thing with the steroids because of the infection, dialysis, obviously for if you're having kidney failure. Avoid UV exposure. That's another thing she mentions, and that's because of the photosensitivity that happens, right? And that makes sense because you're having that side effects of having like photosensitivity. So yeah, just make sure you're wearing SPF. It has to be above 50, specifically something they point out. Mild protein shampoo related to the rash and the alopecia. Steroid creams for rash to help with the inflammation. Report peripheral and periorbital edema. That is one thing for sure, just because their kidneys are being affected. And remember, if those kidneys are able to excrete all of those fluids, they're not working that well. They're retaining all of that fluid, so you're going to see edema happen. So if you end up seeing that, you need to report that immediately. Report signs and symptoms of an infection. So basically, when we went over, your heart rate is high, they're having a fever, the WBCs, things that we talked about with sepsis, right? So small frequent meals because of the inflammation, and you limit the salt intake because we know that sodium helps attract that water. So just limit your sodium intake as a whole is what we tell them, just because again, you're already edematous, you're already inflamed. So we're not going to have you eat more sodium, get more sodium, so you're not retaining more of that water, because we want you to excrete that water, especially if you're having kidney issues to begin with. So again, that's just kind of going over the information. So I would say for Harding, I don't think she'll ask any HIV or lupus questions, because even though she says, like, everything's fair game, like everything in the past, but we haven't gone over this in the past, so I don't remember any questions about that. But we did go over some of that stuff, so you guys kind of can prepare for that for tomorrow in terms of like you're learning it. So again, tomorrow in class, hopefully you can be like, oh yeah, Genesis talked about this, so it makes sense. Okay, so for cancer, I only remember her talking about a couple of things, so I won't go over everything for this one. I feel like I said that with the other ones, but I did. But for this one, I actually won't, just because there's quite a bit on here, and that this could be like its own separate thing. But with cancer, this is a disorder of the immune system. So just remember that. I think we all know what cancer is, but like the actual definition of cancer is it's a disorder of the immune system. So just make sure you know that the risks, exposure to carcinogens, again, you're at increased risk because you're older, with advanced age, genetics, immune systems, hormonal things, infectious diseases, medications, and other lifestyle factors that might affect a patient, right? So carcinogens that can include drugs, hormones, so like birth control pills, chemical agents, physical agents like radiation, gas, pollution, and then HPV, which is another thing that she sometimes points out because you're at a higher risk of getting cervical, head, neck cancers, and penile cancers, right? So usually you can get an immunization for that. So those are just things that she points out. You don't need to know that for the quiz, at least she won't ask about that. But I will say for the exam, I'll try to go over this information with you guys again, just because, or we'll probably go through it next week if we're able to meet. And she does hit on a lot of like different definitions. So like here, it's like she talks about carcinogenesis, which I was able to memorize just because of my name, but like metastasis, things like that. So metastasis kind of makes sense. So it's just like if the cancer cells start replicating and they expand, and basically now you're talking about they're able to keep growing and growing and growing and bigger and metastasizing, right? So maybe she could ask about that. We'll go through some of those definitions next time, because she won't ask you that on the quiz. That's like really, that would be really mean, because you haven't even talked about some of this stuff yet. We'll also talk about grading and staging, because she will ask about that on an exam. Maybe the one thing you have to know here is a biopsy, right? So basically it's just a way to detect things. I think we all know what a biopsy is. So if you go read about it in the book specifically, maybe if you want to read about biopsies, I feel like that's something that you just need to know for this class. So yeah, I definitely do think that is something like, what's the best way to really detect the cancer? The biopsy. So for the rest of that, like, yeah, we'll talk about that, but she shouldn't tell you this. For prevention, you will need to know this, because I feel like she does ask you this, and I feel like I talked about it earlier, right? So this could also be a quiz question, and I feel like it's a pretty easy one. So it's like, again, what's that first line of therapy that we give to a patient? It's prevention first. We always try to prevent things from happening before we start giving them something, right? So if we can prevent it from happening before they get it, that's like amazing. That's perfect. So primary prevention is you prevent things. So risk factors, let's look at what they're doing. So have they gotten a vaccine like HPV, which puts them more at risk? Have they gotten chemo prevention, things like that, right? Are they preventing going to near these carcinogens, things like that? So secondary prevention, that's more of screenings, right? So invasive screening tests, we start evaluating and assessing their family history, what kind of puts them more at risk here. It's more having to do with primary. So secondary screenings, just kind of test things like that. And then tertiary restorative. So after they get this specific disease or anything like that, this is just the morbidity, mortality, management of side effects that we want to see after they already end up having it. I don't think she'll ask about anything like here. It could always be the case. I don't think she should ask about this, because I feel like you haven't talked about this that much. But basically, maybe she'll talk about neoadjuvant therapy, which is basically you're just shrinking before you're removing it. So you're getting radiation chemotherapy. So let's say if a person has a tumor, they'll basically get radiation chemotherapy to shrink it all the way down, so that when they go into surgery, they can then remove that tumor, but it's already a lot smaller. whereas adjuvant therapy is basically after they do that. So they give the chemotherapy and the radiation after they end up having that surgery out. So that just kind of puts them at a more of a risk, not a high of a risk, but there's still high risk of reoccurrence because, like I said earlier, just because you don't have, same thing with like HIV, right? Like just because you have a low viral load doesn't mean that you don't have HIV anymore. Same thing with cancer. Just because you're in remission doesn't mean that you're cancer free, right? So basically, with adjuvant therapy, this is just chemotherapy and radiation after. So usually, if they end up taking out a tumor, you still want to make sure that all of the cancer cells are still gone, right? Because there's still a lot of cancer cells, so you can give chemotherapy and radiation after that. So I could see her asking something like that, but really, I don't think she'll ask about that. Radiation therapy can be external. Internal is brachytherapy. I feel like we talked about it like once in like in second semester, but yeah, just internal is brachytherapy. But I don't think she'll ask about that. Really, it's the prevention, and then honestly, just knowing what cancer is and maybe the risk factors. So again, cancer is a disorder of the immune system. She shouldn't ask about that stuff. But other than that, that's pretty much it. I feel like that's it. So just because we have like 3 more minutes, I'm just gonna go ahead and ask you guys a couple of questions. Don't feel like you have to say the answer out loud just because I get it. I'm one of those people who's really quiet. So I'll just go through and it's funny because I literally showed the answer, but let me see if I can find one. So just go ahead and type in the chat or you can say it out loud, but it's up to you. So which immune response is considered the body's first line of defense? So you have humoral mediated immunity, cell mediated immunity, or inflammatory response, or physical barriers. Perfect, right? So it is physical barriers. So remember, it is kind of tricky because it's like, I feel like she can put out these answers where it's like, it's not 100% on some of these things. Like I'm like, I feel like we talked about different stuff where she tries to trick you by using different words and different definitions. So yeah, just make sure you're remembering how it kind of looks. And that's kind of what I do in terms of exams or quizzes. I kind of just remember like, how did my notes look like? And I try to just think it out. I'm like, okay, innate immunity. The first line was the physical barriers. The second line was inflammatory response. We didn't talk about immoral and cell mediated right there. So that's not going to be it. So yeah, perfect. And then let's go on to this. Furthermore, what kind of barrier is coughing in the immune system's defense mechanism? So coughing is a physical, biochemical, mechanical, or inflammation barrier. So which one would it be? Right, perfect. So with this one, it's going to be C. Because remember, you have those 3 different types. I put in inflammation just to trick you guys. Inflammation was the second line. It's not even a barrier. But physical meaning like those physical stuff that you have, right? The cilia, you have those like tonsils, everything like that. Biochemical meaning you have that saliva, the mucus, the acid in your stomach. So literally bodily fluids, like I literally think chemical. And then with mechanical, those are actual actions you have to do. So coughing, sneezing, vomiting. So that is a mechanical barrier that helps expel pathogens and debris from the respiratory tract, thus aiding in the body's defense against infection. So I'll send you guys this page just because we don't have that much time. And I do have more questions about here, about like lupus and HIV. I will probably send out some questions about cancer and sepsis just in case on your guys' quiz. But really, I feel like I hit on some of the stuff that hopefully she's going to quiz over. And then let me go ahead and stop sharing on here. Okay, and then let me go ahead and show you guys what I'm talking about for Harding's thing. So if you guys want to stay for that, I can go ahead and show you. If not, you guys are all free to go, and I hope that really helped out. If you're wanting to do like one-on-one sessions, anything like that, then we can go ahead and do that in the next upcoming week. I believe I will be able to do it on this upcoming Saturday. I'm going to send you guys an email with a WhatsApp group. So just go ahead and try to join that just because I'll tell you guys what my availability is, just because it's still up in the air until I won't have a set in stone schedule until later. I'll go ahead and send you guys my YouTube channel and that email as well. So the WhatsApp, the YouTube and everything. But yeah, other than that, I hope that helped guys. I feel like sometimes I get a little bit distracted or over the place. And I hope I'm just able to explain how I'm able to think about some of this stuff. So if you want to stay over, if you feel like you were confused about like the fluids and stuff like that, I can explain it again. I do not mind. But feel free to go ahead and go, and then I'll tell you guys that information in an email. But if you guys want to stay to see like how I was able to access Harding stuff, you can go ahead and stay in here, and I can help you guys out with that. But yeah, other than that.